Recording.
Hi, Michelle. Thank you for coming in and meeting with us today. I appreciate you taking the time. We've had a chance to review your resume and would like to ask you a couple of questions. Is there anything you need before we get started?
No, I'm great. It's really great to meet you, and I'm so glad to be here today.
Well, I think one of the things I wanted to start with was was if you could speak a little bit to what attracted you to the position.
Sure. I've always been fascinated, I think even since I was a child, with the notion of psychiatric emergency and what that looked like, though with obviously no real conceptualization beyond television, what that actually was.
Mhm.
And as I've gone through my training, through my master's, I've come to have a better understanding of what that looks like in reality. And I realize through that, like, that my interest maintained, but for a different reason. So away from the sort of sensationalized understanding of it from television, but to the like real humanness of people who are in those dire situations, and the care and support and kindness that they need at truly their worst and at moments where their lives are truly threatened. And I was so excited when I saw the announcement on the news of the opening of this new clinic and the speed at which it was happening. And I was immediately in my mind like, I gotta apply for one of those positions, because through my training, it's just like, it's really become clear to me that the kind of support that people need when they're in at their worst is so essential.
And given the nature of the position and the fact that it's emergency orientated, can you tell us a little bit about your theoretical orientation and how you see that fitting with the job?
Sure, yeah. When I started counseling, it was like I was a narrative purist through and through, all narrative therapy all the time. And I realized that while I do love it and I think it has a place in these kind of emergency situations, it's probably not the strongest choice. So I've started to begin training in solution-focused therapy and learning about brief models of therapy and how to get into what's brought people there very, very quickly and with a lot of urgency. So that's been a really incredible learning for me, and I'm really enjoying that model and getting to know it and incorporating it into my way of counseling. And then on top of that, I approach everything with a feminist, anti-oppressive lens that comes from years of being an activist and a queer person working in spaces where I was often realizing that there was a lot of injustice happening. And I think that's one of those pieces that fits really closely in with psychiatric emergency, because a lot of folks in those situations are facing marginalization in a lot of areas of their lives. So that anti-oppressive lens is something that is really important to me to carry through all of my work, regardless of the model. And I think I'd also really like to learn some CBT things that I can bring in, including motivational interviewing, that I can bring in to sort of get a really quick picture of the problem that brings someone there, and then use other things when we have the time.
And given the nature of the position as emergency based, can you share a time in which you worked with a client in which perhaps the situation was difficult, or perhaps even there was the need for emergency service?
Yeah, so actually I've had a couple of situations like that in the past little while. There have been a number of situations where, as a result of some childhood sexual abuse that people have disclosed, I've had to get both the RCMP and Child and Family Services involved in those situations quite urgently. But I have also had a client who was actively suicidal while binge drinking and using cannabis and crystal meth. And in that situation, I did a quickie kind of suicide risk assessment. She identified a plan a timeline to execute that plan, and um, and had the means in which to do it. She'd also recently been sexually assaulted, and so her mental status was not amazing. She was having a really hard time at that moment. And so we identified with her, and she agreed that she would like to go to the hospital. So using the policies of the organization, we filled out the requisite paperwork and sent her to the Barrhead Emergency Room with staff of the organization. We did not attend with her because the organization itself, we are contractors within the organization. And so the organization is our client, and she is a client of the organization. And their governance structure requires that they take their clients to the hospital. But we filled out forms that indicated the severity of her ideation and that she had a plan and what had been happening in her life previously. So she was able to go with the staff member with the most information possible. Unfortunately, they did not choose to admit her, but she is alive right now, so that's good.
So given the outcome of that particular case, considering you might actually be on the other end of that relationship, so one of the things that we deal with in this position is triaging who is in most need, and community health providers are not always don't always necessarily agree with our assessment. What would you like to have seen happen in your particular circumstance, and how do you think that you would handle it being on the other end of that relationship?
I think there was a couple of things at play in this situation that might be a little bit different. The first is that it's a very small town. So their resources are stretched even thinner than they would be in a big city. And there is no dedicated psychiatric staff. So she's being assessed by folks who have only kind of peripheral training in psychiatric emergency. The other downside of that situation is that she is known in the community to be a person with drug dependency, and has attempted suicide on a number of occasions, and also expressed ideations on a number of occasions, and hasn't followed through. So I think there was some bias at work with the medical providers in the hospital, having known her previously. But in that, all things being equal, I would have loved to have seen her assessed by either a psychologist or a psychiatrist, rather than, they did a blood alcohol. She wasn't drunk, and they sent her home. And they had a quick conversation with her. She said she was okay. And so I feel like the assessment wasn't quite complete at the hospital. So that's one of the things that I would have loved to have seen happen a little bit differently. Were I on the other side, I think is a really good question, because you have to then weigh out your resources, your time, severity, all of those situations. And I think I would have just probably spent a little bit more time with her, just to figure out, like, aside from assessing her sobriety in that moment, also just having a conversation with her about how serious she was, and what she really foresaw happening in the next 24 hours. And just giving it a little bit more time, and also the addition of, in the case of Access 24/7, of trained mental health professionals, psychiatric nurses, psychiatrists, and psychologists, all on site, social workers, all on site, to give those assessments from a more informed perspective. And not to say that the doctors at a small community hospital aren't excellent physicians, but they're generalists, and they work in such a wide variety of concerns in a small town that often I wonder if she was given the kind of assessment that she needed. And so I would be hopeful that she would be given a little bit more time. And that would be my hope for her if I were in the position of being on the other side.
Now, given the nature of the position, many of our clients are high risk, but also quite complex. Mm-hmm. How do you see self-care being an issue, considering that your clients are going to be sometimes at the best of times challenging?
That's a really good question. I think I've realized over the past year that self-care isn't just like taking a bubble bath or getting my nails done, though I do love getting my nails done. I think for me, it's also about self-care is about learning as much as I can, not only about the clients, but about the institution, about the methodologies within the institution, pardon me. So I feel very supported in my job, that I know where my resources are within my work environment, that I know who I can talk to, who on my team is there for me, and vice versa, how I can be supportive of my team members as well. And I also have a really strong social and family support network. I have a lot of people around me who take good care of me, will feed me, will hang out with me, and then I also have I'm working on having a strong physical practice, getting as much exercise as I can to kind of flush out some of that tension that stays. And I've also learned really strongly how to set boundaries, not only with myself and my family and my friends, but also with my clients. And when to say, like, this is an inappropriate conversation, this is an inappropriate line, we're not crossing this line. I've noticed that where it sometimes gets a little bit personal, and just being really careful with myself and very kind to myself, and really assessing how I'm doing and what I could be doing better. And I think I'm really developing those skills.
And as we all do, if you find yourself stuck or overwhelmed in working with a client, what is your thought process in figuring out how to deal with those situations?
For me, I mean, I'm new to this profession relatively, and for me, the number one thing that I always go back to is consultation. I know that this is a team environment, and there are a lot of people with a lot more experience than me, and I feel like if I was stuck, when I get stuck, because it's bound to happen, reaching out to a colleague for some assistance, reaching out to a supervisor, all of those people around who have so much more experience than me will be invaluable in that instance.
Well, that's my list of questions for today. Thank you for taking the time to sit and talk with me.
No problem. Do you mind if I ask you a couple of questions?
Absolutely, please do.
Wonderful. I won't ask you any questions, Scott, but that's where I would.
Perfect.
Okay. So we'll just switcheroo, and I'll just keep recording.
Okay.
So thank you so much for coming in today, Scott. It's such a pleasure to meet with you. Before we get started, I would just love to find out from you what attracted you to this position and what inspired you to apply.
So I've been working for the past 13 years with students who have received a diagnosis of one kind or another. In those 13 years, predominantly within what would be determined as, or what would be named their accessibility department. My job there is to build a support plan and to determine academic accommodations based on the documentation that we receive from a registered healthcare provider, but also from doing a clinical style interview to see how that those diagnosis or multiple diagnosis present with that particular client. Part of my journey into counseling came from needing better clinical skills to connect with my clients who have very complex histories, very complex diagnosis. And I found that as I delved deeper into my master's, but also into the work itself with clients, that I found that the counseling piece, as much as those support plans and those academic accommodations are important, I felt as if the real work was being done in the therapeutic or within the clinical realm. I felt as if that was the place in which real change was happening. And added to that, I think part of my attraction to this job and to post-secondary in general is that our post-secondary experiences, myself included, who's been back to post-secondary multiple times, I feel as if part of the journey of post-secondary is a process of self-determination, of determining who we want to be, not just now, but in the future. Colliding with that sort of philosophy, though, is also the fact that we have young people who are being diagnosed. The Mental Health Commission of Canada said that diagnostic rates for mental health are up 33% in Canada, which is huge. It is an astronomical jump. And we've always known that within those statistics, that young people between the ages of 18 and 24 in particular are often more at risk or highly at risk for the onset, if not necessarily a diagnosis, but an episode of mental health or a mental health challenge. So I feel as if this is a place in which there's a need for a tremendous amount of support, and that the college's resources, and that I can add to the college's resources as a whole.
Thanks, Scott. So can you share with us the methodological, that's a terrible word. Can you share with us your sort of theoretical orientation and how you see this being applicable in this role and in the things you brought up around creating self-determination for young people and within the kind of college experience?
So I think there's multiple layers to that. I think the first piece is, regardless of what your theoretical orientation, we at Mohawk have a very diverse population, from international students to what's known as first gen, or the first people within their family to attend post-secondary for the first time. We have a large contingent of Indigenous students coming from alternative schools. We have a very diverse population that feeds our school as well. Most of our population comes from the geography surrounding us rather than from outside of the city of Hamilton. So we've got some definite pieces in which we have people that are identifying along a variety of different intersectionalities, people that might have multiple identities and that in some ways are in conflict. Often I see, added to that is I often see the conflict between students' values, the individual students' values, and parent values, and how that has situated them within maybe an academic program that they're not necessarily actually interested in, but feel that they need to please parents. So there's a definite need for an awareness of inclusivity and a anti-oppressive framework, so that me as a heterosexual white male who's a little bit older, I'm not bringing myself to the table in such a way in which their voices can't be heard. So that's sort of the ground floor in terms of that piece is a necessity in working with the diversity of our population. I think the second piece to that is also my theoretical orientation. I would actually have to say, I like to think of myself as a narrativist, but actually I think I'm more psychodynamic than I am narrativist. And that is actually, again, sort of mutated into the fact that, well, I use elements of both of those, knowing that they're supposed to be, theoretical enemies. I do find that I use both of those approaches in a more solution-focused way. I tend to be, and solution-focused tends to allow me to be a little more directive and goal-orientated, which is appropriate in our setting because students are going to have a limited number of sessions, and our job is not to be mental health. It is not as a mental health community resource. Our job is to help them achieve the goal, their post-secondary goals, but also help them connect with community-based resources that can also help support them outside of the post-secondary environment as they graduate. Because the average amount of time, or the average amount of time that a student stays with us at the college level anyways, is only 2 years. So part of this is about community facilitation as well as providing a brief model of service to attend to the immediate.
Wonderful. So you mentioned the brief model, and I'm wondering what interests you about this model and what are the challenges that you see within this model?
I think so. The piece that I actually really like with brief models is I do tend to be able to be more directive and provide maybe alternative perspectives to students to see whether or not those alternatives might resonate with them. To offer them my perspective and see whether or not that perspective or my experience of them shows them a side of themselves in which that they haven't necessarily considered. And I found that those opportunities have been very powerful, and that the pieces that I have, the strengths that I am able to see as they share sometimes some very complex and very devastating stories, especially with our international students who have at one time been refugees, to be able to share how powerful their story is for me allows them to feel a sense of agency that I might not necessarily be able to promote if I was taking a longer term approach and I was not able to take a more focused, strengths-based approach. The the downside of the model is it is what it is, right? We've got 5 to 8 sessions, right? 60-minute sessions, and some students, the complexity of their needs are, you simply can't cookie cutter somebody into such a brief model when there's been years of abuse or trauma or complex diagnosis and outside health care providers. So part of that is we are right next door to one of Southern Ontario's largest hospitals that does mental health work, and we share a lot of clients with the hospital who have very complex needs, and the brief model is not necessarily equipped to deal with that complexity, unfortunately.
So this, like, as you mentioned, you see a lot of clients with very complex needs and very complex stories. And as you take these things in, they can really have an impact on you as a person. So what supports do you have in place, and what are some of your self-care practices in order to mitigate some of the potential vicarious trauma that you may experience?
I think I take a very value-laden approach to self-care, which is a tremendous amount of my resiliency comes from the fact of valuing the work. And I've found that I can carry tremendous stress loads if I am committed to that piece, and if I believe that we're able to provide a supportive environment for those students to accomplish their goals. In my previous career, I was a military officer, and I was in there for quite some time. I was there for 14 years. I eventually left the military because I realized at some point that while I had made some individual difference in people's lives, I knew that I was never going to make any systemic differences, and that was the reason I had left the military in the first place. I think as much as the individual change and making individual change is important with our students, we also need to look at a systemic level. I'm not just trying to help one individual change. I am trying to be part of a system that allows young people to reach their potential. And that part is important to me. And that's one of the reasons why I targeted post-secondary. So being a part of that, the creation of that community, as well as the individual success stories or individual outcomes, are the ones that keep me going when there are students that are just not ready to make that journey, right?
Yeah.
Or need an additional time. I think also the other thing though is that I've had to balance that with the fact that I am getting older. At 46, I'm not physically resilient in the way that I used to be, and I do need to be taking more time to recover. I pushed myself to my physical limits this past semester, and it's resulted in me being sick multiple times. I don't think I would be as vulnerable to illness had I taken better care of myself physically. So that's a lesson to learn with age, and one that I continue to work at.
Wonderful. When you get, because it's bound to happen, that when you feel you get stuck with a client, what are some of the strategies that you employ to manage that stuckness?
I think part of this comes from my military career, but I take a very team-based approach to everything. I have wonderful colleagues that I can connect with and share those experiences with. I also have a wonderful clinical director that I can connect with on a regular basis, who has provided that opportunity for reflection, but also provided that place in which there is emotional safety as well. And as you struggle through some of these things, some of which are very triggering, my international students that are refugees can be very triggering for me, considering my own history of violence in places in which there's a lot of instability. So I've definitely had to tap into those resources at time, and they've also provided not just the self-care pieces, but also, and the reflective pieces, but also the professional growth opportunities to begin looking to reframe, to begin to see how to thicken narratives that perhaps students ensnare me in because they're very complex and they can be overwhelming at some times. That ability to step back and take a breath and re-strategize your approach and learn new skills has been invaluable.
Wonderful. That brings us to the end of our time, Scott. Do you have any more questions for me?
No, I think I'm pretty comfortable with the model and with the institutions. As I said, I've been working in this industry for some time, and I've been with Mohawk for 5 years. I'm very, we work very closely with the counseling team already, so I think I have a fair idea of what I'd be walking into.
Wonderful. Well, thank you for your time this afternoon.
Thank you.